Hey everyone, it's Naveen again. Today's topic is hypercalcemia for nephrology in the ICU. This is one that comes every so often and actually can be really serious, and that's why you might be the first doctor to see this. And I think it's not very hard to manage, perhaps maybe a little harder to work up. And you can do a lot of this before calling for help or as you're calling for help. And so I want us to be equipped and ready for that. So hypercalcemia, I'm going to spare you the details for what symptoms, think back to your stones, bones, groans, psychiatric overtones. But say you were consulted in the ICU because a patient is altered with a calcium of 18, and you're admitting this patient. What's going to happen? What are you going to do about it? Right? Um, and you may be concerned about, are there going to be any cardiac effects, mental status? Is this patient going to be protecting their airway? What's their muscle tone look like? All these other things as well. Are they in frank renal failure? These are things that you might be called for in the intensive care unit. And so you need to be able to work on this really quickly. Let's start by having a framework for the workup that you're going to send off. Now, in a patient who's only mildly hypercalcemic, I suppose that it's acceptable to hold off on doing the entire workup, maybe just start with the very, very beginning of it. But once you're in the intensive care unit, I don't think it's wrong to try and expedite and get as much of the workup as possible, because some of this workup do take days to come back for many institutions if you don't run it in-house. But let's go ahead and get started with the workup. So the first thing that you're going to look at is the PTH. So this is going to be the first branch point. PTH is referring to our parathyroid hormone, and processes for hypercalcemia will either be PTH independent or PTH dependent. So dependent here, and independent over here. Now, most processes that end up in the intensive care unit are actually going to be the independent processes. It turns out that PTH dependent processes tend not to be um, super high calciums, maybe 12, 13, sometimes a little higher, but almost always this is not going to be this side of the course is not going to be what you see in the intensive care unit still. We will go over the two main etiologies, and that's going to be your hyperparathyroidism, so hyper PTH, and it's also going to be your familial hypocalciuric hypercalcemia, FHH, which generally only has a calcium of like 12 or so. We're going to spare the physiology here for FHH, but perhaps recognize that both of these are associated with high PTH, leading to increased calcium in the serum, although FHH is actually a lack of ability to respond to PTH. Hyperparathyroidism is truly PTH effects on bone vitamin D production, 125 vitamin D production, and calcium absorption. Now, I mentioned though that most of the hypercalcemia that you'll see in the intensive care unit is PTH independent processes. That's because these processes can get actually very out of hand with very, very high calciums that lead to some of the scarier symptoms. And this is why I say send out the workup, because by the time they're coming to the intensive care unit, it's most likely going to be these non-PTH dependent processes. And the three tests that you should be really looking at are going to be, let's quickly change color here. Your three things you're going to be looking at is your PTH-RP, your 125 vitamin D, or calcitriol is often the name of the lab test. Calcitriol is 125 vitamin D, and then your other processes that are not going to be PTH-RP or 125 vitamin D dependent. Um, and in vitamin D, I'm also going to put just regular old 25 vitamin D. Usually it's not going to be a 25 vitamin D process, but some people do take a lot of vitamin D or believe in taking lots of vitamin D, particularly on the internet. There's a lot that goes on about vitamin D being, very important, potent, and so people use it for all kinds of things, and you'll see some really ridiculous levels of vitamin D sometimes if someone is taking too much of it. But PTHRP are going to be associated with oftentimes your squamous cell cancers, particularly breast, head, neck, lung. These cancers can be PTHRP secreting, but it turns out there are actually others that can be PTHRP secreting, such as renal cell cancers, carcinomas, and paraneoplastic syndromes in general, like, can still be rare, rarely caused by other things, and so we can't you know rule those other things out. One that I saw recently that I thought was quite interesting was a neuroendocrine tumor. Um, and yeah, and so in these processes, if you see a PTHRP that's elevated, or you have a history of these other cancers, you should be associating the two together and be looking for the other one. So for example, say this is their first presentation as hypercalcemia, you get a PTHRP, you should be looking for these other cancers. Versus if you already knew that they had these cancers, they're coming with hypercalcemia, then you should be thinking your suspicion for PTHRP should be high. Now, on the other hand, so just gonna block these off over here. On the other hand, 125 vitamin D or calcitriol can be very high in particular processes. For example, like small cell lung cancer. It could also be in macrophage dependent processes. So this is something like sarcoid or TB or lung fungal infections. PJP is another one that I recently saw. And these processes can be high calcitriol or high calcitriol dependent processes. Um, Finally, under other, let's move this over here. So under other, you have your hypercalcemia of immobility. You have your lytic bone lesions when you have certain cancers that cause bone lesions like breast or prostate, for example. Your multiple myelomas can get really, really high calciums. Um, um, yeah. And then sometimes ingestion of really high calciums, so like your milk alkali syndromes, for example. This happens rarely now because we don't usually use like a combination of alkali and calcium like Tums to the high quantities that we used to use in the past. Um, but this is an example that might possibly do it. Um, and then, the last point that I'll make, because the workup here is maybe something everyone's familiar with, but the last point that I'm going to make is that please recognize that these tests are not binary. Now, in most institutions, what do I mean that most institutions, we have really wide ranges for what's considered positive or not positive. For example, PTH at our institution is something like 30 to 110, and calcitriol is something similar like 30 to 70. But these mm, um, these hormones, these steroids, these things that we use are actually very sensitive to the surrounding environment. So, for example, when calcium is low, PTH can be quite on the higher side, such as 90, 100, especially in vitamin D deficiency. But when calcium is high, we have a very good ability to suppress our PTH to below 20, okay? And what I mean by that is if say you have a patient whose calcium is 10.8, okay? But you see a PTH of 90, this is definitely primary hyperparathyroidism. Definitely. Diagnosed. Done. Right? This is not normal. It should not be like this. I mean, you can argue, okay, what about vitamin D deficiency? Well, the calcium shouldn't be 10.8 in vitamin D deficiency. You should be really concerned that you need to interpret these tests in the context of the surrounding markers. What should our body's response be? Again, a hypercalcemic patient should not have a calcitriol of 68 or 70, okay? If it's in the red range, it's 120 or 80, okay, great, wonderful, but please, just because it's not a red number or not marked as high or low, please make sure that you don't forget to interpret it in the context of what the actual calcium is, okay? And one other comment I'll make is please make sure that every time you get your calcium, that you check an albumin at least once in the admission, maybe a CMP at the beginning of admission, so that you can adjust the calcium. Particularly our really sick malnutrition patients might come in with a low calcium, but it turns out their adjusted calcium is actually on the quite much higher side. I had a patient recently that I diagnosed with PJP pneumonia. He came in with hypoxemia as his main problem. His calcium was noted to be something like 8.6 or 8, 7.8, and then slowly trended to 9.2. This whole time it was in the low red to black number range. But that increase within just a few days was concerning enough to me, especially when you take into account the albumin. Um, uh, that this patient actually had really bad um, production of calcium for some reason. We diagnosed him with a calcitriol dependent process, which solidified PJP. We empirically treated for PJP until it took time for the Carius test to come back positive. And when the Carius test came back positive, it confirmed PJP, which I think was a really cool way of diagnosing the disease and helped the patient go from really, really bad hypoxemia. Just every time he moved, he was desaturating. That probably saved him an intubation, and because we started treating quickly and everything normalized very rapidly, which was awesome. I will say one more thing that can cause hypercalcemia, and it's the most common outpatient cause of hypercalcemia, is HCTZ or thiazides. Now, these usually are not going to come to the ICU, so that's why I'm not going to comment on them much further than that. All right, so that's the workup of hypercalcemia. We should now talk about the renal effects of hypercalcemia. So I know that this isn't the most important thing to every ICU physician, but this is a nephrology in the ICU talk, so how can we not include the importance of or the effects of hypercalcemia on the kidneys? Okay, and there's a few things that we should be aware of. So hypercalcemia causes acute kidney injury. And it does this through multiple mechanisms, but the main mechanism is vasoconstriction. We're all aware of, especially in the ICU, I'm sorry about this, I'm having some technical difficulties with my pen. There we go. Um, We're all very hyper aware of the importance of calcium for adrenergic response. So it turns out having too much calcium causes severe vasoconstriction of the afferent and efferent vessels and vasorecta, and so you're going to get local ischemia to the tubules. You can get ATN from severe hypercalcemia. You're also going to get volume contraction. and we'll talk about the mechanism of volume contraction in just a second. But volume contraction is going to also lead to, in the combination of this vasoconstriction, is going to lead to acute kidney injury. And over time, you can get nephrolithiasis, you can get interstitial and tubular injury due to um, nephrocalcinosis. And so these are ways calcium can be harmful to the kidney, and just keep that in mind. The second thing that we need to be aware of is how it causes volume contraction, and does that through natriuresis. Okay, so we're going to draw a renal tubule really quickly and talk about how. And I think this is actually a really cool mechanism. And I think when we talk about it, it should hopefully stick really well. So, how does it cause natriuresis? We're all aware of FHH. In the ascending limb of the loop of Henle, we have this is where familial hypocalciuric hypercalcemia is usually diagnosed in the form of mild hyperparathyroidism. We have calcium sensing receptors in this region. Now, these calcium sensing receptors, so I'm going to zoom out a little bit and just look at these calcium sensing receptors. When calcium or magnesium binds these calcium sensing receptors, the way they work is that they inhibit our sodium potassium chloride cotransporters in the ascending limb of the loop of Henle. Right. So, and why does that make sense? Well, calcium is absorbed through paracellular transport in the ascending limb of the loop of Henle. And normally, when we absorb sodium and potassium and chloride through the cotransporter here, we have these K channels that allow potassium to exit, creating a positively charged lumen. This positively charged lumen then pushes calcium through the paracellular pathway, and that's how we absorb calcium, and one of the mechanisms of absorbing calcium in our nephron. So when we have excess calcium in our serum, we need a way of modulating the amount of calcium we're absorbing back from our urine. So excess calcium then binds our calcium sensing receptors in the ascending limb of the loop of Henle. This leads to inhibition of this sodium potassium chloride cotransporter. And this leads to inhibition of creation of this lumen positive potential. By inhibiting the lumen positive potential, because potassium is not coming intracellular to then be driven out by this channel, we cannot absorb our calcium through the paracellular means. And we end up getting, we lose our calcium. But by doing this, we also inadvertently lose sodium, right? By not absorbing sodium in the ascending limb of the loop of Henle, we lose sodium. And so sodium is then going to leave via the urine, and you get natriuresis. And remember, volume is salt plus water. And so by losing our sodium, we're going to eventually get volume contracted. Okay, this volume contraction is naturally going to lead to an increased renin-angiotensin aldo system, and so your RAS is activated. By RAS activation, we increase our sodium absorption here in the proximal tubule. Since calcium is absorbed via paracellular pathway transport in the proximal tubule, we also absorb more calcium here. This leads to a feed-forward loop where volume contraction ultimately leads to worsening hypercalcemia. So hypercalcemia leads to volume contraction. This activates RAS. This leads to our attempt of absorbing sodium and calcium in the proximal tubule, which worsens the hypercalcemia that we're already experiencing. Okay? Now, fun fact, this calcium sensing receptor activity mirrors and mimics a Bartter syndrome. Why is that? It's actually one of the types of Bartter syndromes that you can get when you have a mutated overactive calcium sensing receptor. you will get a Barter's phenotype. And so Barter's has many mutations. One of those mutations, uh, uh, I believe the type 5 Barter's, and specifically is this calcium sensing receptor. So however you remember it, hopefully that makes sense here. Um, um, and it's a Barter's phenotype. Hypercalcemia can mimic a Barter's phenotype by overactivating the calcium sensing receptor. Okay, um, so that is natriuresis. Now the next mechanism is aquaresis. As we all know, ADH is important for diluting and concentrating our urine, or helping regulate our concentration of our urine. And ADH activates the aquaporins in the collecting ducts. Turns out what hypercalcemia does is calcium eventually leads to inhibition of this aquaporin activity through and by inhibiting the aquaporin activity, you have water losses in the urine, and so you get aquaresis. What does this aquaresis do? Well, it leads to hypernatremia. So you can get a volume contracted state with hypernatremia and acute kidney injury in these instances. And so that's something that you should be aware of. All right, so these are effects of hypercalcemia on renal function. And now I think we can go to how do we treat hypercalcemia. In treating hypercalcemia, I think in some ways is straightforward, some ways is in the moment can be kind of difficult if you're not prepared to do it. So the first thing that we're always aware of when a patient's coming into the intensive care unit for hypercalcemia, presumably it means that they're very significantly affected by the hypercalcemia. Now, most of the time, the level of hypercalcemia we're talking about is greater than 14 or greater than 12 with obvious symptoms. I suspect that most patients, that just because they're greater than 12 with symptoms, will not come to the intensive care unit. They'll be treated on the floor with the appropriate treatments with endocrine oncology or nephrology help. But every now and then they may end up in the ICU for whatever reason. Greater than 14 may end up in the ICU. Generally, I would suspect something greater than 16 is where people are starting to get worried with really bad altered mental status or cardiac dysfunction, for example, or renal failure. But the first thing that in these really symptomatic patients is that we need to reach to calcitonin. And calcitonin is dosed as units per kilogram. And the dosing is either 4 or 8 units per kilogram. And very importantly, we experience tachyphylaxis to calcitonin, meaning after the first few doses, usually 4 doses, we start to see less and less effective calcitonin. And calcitonin is temporary. It also is not incredibly powerful. It might get you down 1 or 2 points of calcium, but I think maybe it's a little overblown on how good it is. And so we often see patients start with this 4 units per kilogram of calcitonin. I urge you, especially in the intensive care unit, if you're accepting these patients, just start with 8 units per kilogram. You can always hold a dose or stop a dose, but these patients, if they're this severely ill and you're planning to medically treat without dialysis, this is the way to go. 8 units per kilogram times 4 doses, because if you do 4 units for a day, well, guess what? You only have 2 more doses before you're really going to get less impact of the calcitonin, and so it's a waste by, you only get 2 more 8 units per kilogram doses. You might as well just start with that, okay? So that's calcitonin. The next thing is fluids. Fluids. This is massive. Give tons of fluids. If this patient looks like their volume contracted in any way, I understand pausing if a patient has severe heart failure or renal failure. I understand pausing. That being said, these patients should still get quite a bit of fluids. I'm talking even a patient with severe renal injury and heart failure should probably at least get 2 to 3 liters of fluids right off the bat, and then you decide. I'm not saying give 500 and then pause like maybe we do in other cases. I'm saying give 2 to 3 liters right away. Patients who have good kidney function, don't have heart failure, probably need even more than that. I'm saying maybe even like 5, 6 liters of fluids at times. Okay, and why does fluids work? And which fluids are we talking about? So, we mentioned that one of the mechanisms of hypercalcemia that leads to its own positive feed forward loop is that hypercalcemia leads to increased RAS activity. So, this RAS activity leads to increased sodium and calcium absorption in the proximal tubule. If everything is absorbed in the proximal tubule, because of this volume contracted state and RAS activity, you're going to lead to difficulty peeing out your calcium, right? Like you're going to have difficulty peeing the calcium out, which is what we want. We want to use the kidney's ability to pee out calcium. So my favorite choice of fluids is normal saline. Why does it do that? Well, first, it tanks up the afferent efferent vessel and shuts down some of our tubular glomerular reflex, myogenic reflex for volume contraction, and it turns off our RAS state, right, by increasing our sodium and our chloride delivery to the ascending to the macula densa. We're going to shut off our RAS activity, and this shuts off our sodium and calcium absorption in our proximal tubule. The sodium and calcium can then the sodium and calcium can then continue to be delivered uh, through to the distal tubule where it can then be excreted. Now, a lot of people use LR. You're not going to be wrong. Remember, the key is shutting off RAS. LR is going to do that. My thought process is just not the cleanest way of doing it. Why do I say that? LR has calcium in it. It's a very tiny amount of calcium. But still, if you're going to be sort of perfect with your intervention, to me it seems like sodium chloride, normal saline, is the best way of shutting off RAS in this instance. It's the cleanest way, but you will not be wrong by doing LR either, technically speaking. Okay, so fluids. Fluids helps shut off this feed forward loop of reabsorption of calcium in the proximal tubule because of the natriuresis that calcium causes in the volume contracted state that calcium caused earlier, right? So that's why we do fluids. 3 is diuretics, particularly loops. Now, this has to be done in conjunction with fluids, and there has to be good working kidney function. Diuretics are going to, loop diuretics in particular, are going to inhibit your NK2Cl cotransporter here. By inhibiting your sodium absorption in the proximal tubule, remember this leads to less calcium traveling through the paracellular transport pathway, and so this leads to calcium losses in the urine, right? This is something that we know, Bartter syndrome, loop diuretics lead to hypocalcemia. And what you will then do is stop a thiazide if they're on it, right? So you stop the thiazide, okay? So these are our first 3 interventions that you're effectively going to do in most patients that you deal with that have hypercalcemia, all right? What about other interventions? Other medical interventions you're going to think about are bisphosphonates. You're probably going to reach for zoledronic acid. Probably not pamidronate, but you can. Some places to use pamidronate. Zoledronic acid, remember, has to be given over 15 minutes, and it's usually 4 milligrams, I believe. The reason is zoledronic acid is associated with ATN, particularly in volume contracted states, and so it's kind of dangerous to be giving, and that's why the push is meant to be given over 15 minutes. When evaluated, giving it over 15 minutes is virtually not associated with acute tubular injury. That being said, I have seen a case where I'm confident it was the zoledronic acid and I couldn't explain it any other way. That I could have been wrong in that situation, but the patient played out with an ATN event and improved over time. It's impossible to tell, but just remember that the protocol should be giving it over 15 minutes. Now, at my institution, it's automatically ordered that way, but if you're anywhere else, please just make sure that's the way your zoledronic acid is being given. Now, the next thing to consider is steroids. And briefly going back to bisphosphonates, these are particularly useful for most hypercalcemia situations and emergencies, but you can think pathophysiologically it would be great for lytic lesions, immobility, um, PTHRP, calcitriol, right? Essentially every situation that you can think of, PTH, because it just shuts down the bone turnover, right? Now steroids, the way they work is they inhibit 125 vitamin D. And I think this is actually a really cool piece of pathophysiology that we can talk about in just a little bit. But they shut down 125 vitamin D. So these are really good for your macrophage or calcitriol dependent processes, right? Macrophage processes are usually calcitriol dependent. And so these things are like your sarcoid or your malignancies that are calcitriol dependent. The next treatment that you might think about, and oftentimes this is a really expensive treatment, so you have to have failed everything else, but this is your denosumab. This is a rank ligand antagonist inhibitor, and how this works is it shuts off your osteoclasts. By shutting off your osteoclasts, you're going to have less bone breakdown. It lasts a really long time. It's very potent. Now, all three of these, the bisphosphonates generally take about 72, 48, 72 hours to really kick in. Same with steroids and denosumab. And so you need those initial treatments up front to buy yourself some time. And these therapies then will knock your calcium down by quite a lot. In fact, very frequently you get hypocalcemia and run into trouble, where you may even be doing a calcium drip for a brief period of time just to stabilize them out and prevent the symptoms of hypocalcemia. All right. So these are three of your main medical treatments, but I'm going to list one more that I think is super cool. And the reason this came up is when I was taking care of a patient with neuroendocrine tumor, we had a situation where these therapies seem to have been struggling. And one therapy you can think about is ketoconazole. Now, why is this the case? Well, it turns out that for your calcitriol dependent processes, so your 125 vitamin D, right? You usually start with you usually start with 25 vitamin D and then 1 alpha hydroxylase converts it. But one of our mechanisms of inhibiting this is 24 vitamin D. And I'm going to come back to this. Sorry, 24 vitamin D hydroxylase. And these mechanisms inhibit, by adding this hydroxyl group on the 24 spot, you inhibit the vitamin D activity, the calcitriol activity. Well, these two enzymes are cytochrome P450 enzymes, and ketoconazole inhibits cytochrome P450 enzymes. So in a calcitriol dependent process, by inhibiting 1 alpha hydroxylase, you may reduce the amount of calcitriol development that there is. However, the downside of using this treatment is that you also inhibit the natural inhibitory enzymes of 24 vitamin D hydroxylase, which may uh, convert your active calcitriol to inactive calcitriol. So if a patient already has very high calcitriol levels, it may be a little harmful, but it would prevent further production of calcitriol and calcitriol dependent processes. Now, our neuroendocrine tumor patient was having difficulty controlling they had a PTHRP dependent and calcitriol dependent process. And so our thought was if we can just somehow get the calcitriol under control, this would help prevent the hypercalcemia to some degree for this patient. And so we were strongly considering ketoconazole. All right. Now, the last therapy that I want to bring up is dialysis. In situations where, and this is going to be clinical judgment and comfort, um, we can use dialysis, and within one session, we can really normalize the calcium. How do we do that? We can use a low calcium and normal calcium bath on the dialysate. Just really take out all the calcium, normalize everything in a session. It'll get you out of a pinch, particularly really sick patients. Patients that maybe have really bad acute kidney injuries already, and you're not willing to waste time on them. I will say that I've taken some really severe hypercalcemias greater than 18, for example, and I have still just done the usual calcitonin, fluids, diuretics, with the caveat I may have to consider dialysis, and I have gotten away without using any dialysis. So that's what I mean by comfort. If you understand the physiology, I think you believe you have the renal function to spare to actually allow for calcium losses in the urine, then you may be able to get away without dialysis. Even within just a few hours, you should see the calcium coming down. But dialysis alone is not wrong in these situations because dialysis is a surefire way of fixing it very quickly. It's just that it has the risks of initiating dialysis, a catheter placement dialysis, not a harmless intervention as well, but it works very quickly. All right, so that's how you would manage hypercalcemia. Thank you.